Thank you for the opportunity. All right, so we are assessing the impact of morbid obesity on post-esophagectomy leak rate. Okay, so none of our authors have any disclosures. Of note, Dr. Wood is the PI for the Newton Foundation grant as well as the CEDAR grant, which are both our institutional grants. So some background, over 40% of the US population is obese, with a BMI increasing the risk of developing esophageal adenocarcinoma, and some studies have recommended that this is a dose-dependent reaction, with one study demonstrating that patients with a BMI of greater than 30 had a 16% greater chance of developing esophageal adenocarcinoma than those with a BMI greater than, 22% or less. So for our methods, we did a retrospective review of patients undergoing esophagectomy from 2016 to 2019, and this was using the esophagectomy-specific NSQIP database. Of note, this database did start in 2016. We then stratified patients to a BMI greater than 35 and less than 35. Of these, there were 4,165 patients with a BMI greater than 18.5, so we did admit those who were underweight because they do have their own subset of complications that we did not want to affect our outcomes. Of that, 10% of the patients had a BMI greater than 35%. Patients with a BMI greater than 35% were more often younger, with a mean age 4 years younger. They were also white, female, non-smokers, diabetic, demonstrated to have hypertension requiring medication, and an ASA of at least 3.
Small red.
Small red. Oh, the monitor's over there. Okay. All right, sorry, getting a sneak preview there. So the results for our BMI greater than 35 cohort demonstrated that there were longer operative times, as well as surgical site infections, return to the operating room, as well as leak rates, with a difference of 13.5 versus 10%. However, for all diagnoses, this was not an independent predictor of leak. We did do a subgroup analysis, which did demonstrate malignancy and dysplasia for those with greater than 35% was predictive of leak. And here's our first multivariate analysis table, which demonstrates all patients, not all patients. And then this second table demonstrates our multivariate subanalysis of dysplasia and malignancy as the indication for esophagectomy. And as you can see, the patients do have a statistically significant rate of leak. And so for our conclusions, we demonstrated that BMI greater than 35%, undergoing esophagectomy demonstrated greater anastomotic leak rates and was independently predictive of a leak when esophagectomy was performed for dysplasia or malignancy.
Thank you very much. If there are any questions, please come up.